Hi, everyone. Welcome back to the Health Tech Edge. I'm Mike Moore. Today, I'm speaking with Mark Nelson. Mark has spent his entire career inside healthcare, first on the health system side and then in healthcare tech. He helped build internal consulting and analytics teams at Allina Health, was part of the early Health Catalyst story, and later ran partnerships with major cloud and data platforms. We're going to talk about a pattern a lot of strong healthcare organizations go through, the cycle where you build capability in house, then bring in outside help for scale or speed, then build again when the next wave of tech arrives. It's not about pointing fingers, it's about understanding why the cycle happens because when you see it clearly, you can steer it better. And AI is just the latest place where the cycle is showing up fast. Mark, thanks for joining me. Glad to have you here.
Mike, it's an absolute pleasure. Thank you so much for inviting and having me.
Yeah, absolutely. I think that a lot of people, when we look at what's happening with AI, you hear a lot of talk about things being unprecedented, and I think in many ways that is true. But I've been in tech for over 30 years now. Not that I feel old enough to say that, but it's true. You've got some years and miles as well in kind of this industry. I think it does help to take that perspective and kind of take a step back and see, when have we seen these patterns before? But let's go back a little bit to the beginning. Just kind of your career path and kind of the quick version of it. You've been on the provider side, the vendor side, now a newer AI company. What were some of the big chapters and what did that teach you along the way?
Yeah, I've been fortunate to have a career that has had three, I guess what I would say is very three specific, but at the end of the day, looking back, interconnected acts. The first of mine was really at Allina Health, as you mentioned, where I worked. I came in and worked in internal consulting and operational analytics. It was during that period that Allina became one of the very first early adopters of Epic. And we learned pretty early on during that implementation that while Epic was great for its intended purpose, which at the end of the day really was for billing, it wasn't great for analytics. And so we had to build tools and processes to be able to get data meaningfully out of Epic and to be able to use it. And that period really taught me how change truly takes hold within a health system and the power that data can have in making real meaningful change, both on the operational side as well as on the clinical side. The second act was at Health Catalyst. And so moving from really working on the provider side to a healthcare IT vendor. Within there, I moved into the corporate development and M&A and did a lot of work with other organizations that we did acquisitions to and just really getting a pretty strong flavor in terms of kind of that whole development life cycle with healthcare IT. And from M&A, I moved into more partnerships, and those partnerships were really around some of the really big cloud and data platforms. So think of Databricks and Microsoft. There, I learned what really truly scales. You'll see where strong ideas falter or where they meet the complexity that, you know, basically many different health systems and where disciplined infrastructure at the end of the day makes a real difference. And how does that complexity play out? The third act is what I'm doing now is starting to work with a couple of really interesting startups like Intelligible. And our focus with Intelligible is making structured healthcare data genuinely usable with large language models. It, if I'm honest, the work I'm doing really draws kind of directly from those first two acts of my career, the need for interpretable, operationally relevant insight and the need for solutions that function reliably at scale rather than, what you might consider like isolated pilots.
Yeah, that's great. So I love the way you look at it too, with the different acts of the play here that you're seeing in your career, and I think it's a great opportunity having those different perspectives and the different lenses. Certainly, I'm sure gives you a high degree of trust and empathy, and probably some sympathy for customers as well in healthcare. Right? It's not easy
Absolutely.
having walked a mile in those shoes. You know how challenging it is. Um,
Absolutely.
where you've had this big focus on data across the career and kind of going back to your start and doing things like predictive analytics, maybe doing some of those models before it was fashionable. When you look at some of those kind of early works, what problem were you trying to solve, and kind of what was the most useful out of that experience?
Yeah. First off, I want to be really clear that I was really fortunate at Alina to work with some incredibly smart people and some very strong leadership that was supportive and allowed us, frankly, to be really creative. It, to answer your question, when we started building some of those early predictive models, the problem we were trying to solve at the end of the day was very practical. Most of the risk models at the time were built almost exclusively on claims data. So think of something like the LACE model for readmissions, which meant you learned that someone was at high risk for readmission after they actually left the hospital. So, what we tried to do was to challenge ourselves to build models that only utilized variables that were available while that patient was still in the bed. And the real breakthrough was not necessarily predicting the risk for its own sake. And to be a little bit flippant, that part wasn't actually that hard. It wasn't that hard to say who's at risk for readmission. The hard part was identifying who are the patients that you can actually impact and move that inflection point away from someone who's at a high risk for readmission to someone who's maybe at a lower risk. How do you blunt that curve? And what of those things could we influence? And so those were the patients that we wanted to identify and what we built the models to identify, where we thought a change in follow up maybe was discharge planning or kind of what kind of transitional care they would be in. It could actually alter the trajectory. This is at the end of the day what we found makes these these models useful on the ground, which is you know helping the resource constrained care managers, social workers really concentrate their effort where it genuinely was able to impact outcomes rather than working from, a broad list of patients with no clear path to intervention. And in many cases, traditionally had just kind of used their own internal gestalt, for lack
Mm.
of a better term, to understand who they need to focus on. So we were trying to bring a more um, data centric approach, and it ended up being pretty successful.
Yeah, I think that a lot of organizations struggle with data, and I think the timeliness, as you just mentioned in your response, that we see so much data accumulated throughout, all the different systems and the stay and all that kind of, but the ability to quickly turn that back into insights uh, while the patient is still in the hospital, so that interventions can then, and kind of knowing what interventions can be put in place to try to affect things in a near real time fashion. I think, given that was a previous chapter in your career, it's something many organizations still struggle with, right? This is not
Absolutely.
easy stuff.
Gosh, not at all.
So, when you look at some of that in terms of, I know part of that's kind of looking at length of stay and kind of the impact. What were some of the metrics that you were tracking with the team or looking at to try to improve the overall operations there?
Yeah, and I will. It's a great question, and I would answer that and have by this. I still have a really strong passion for length of stay. And during my time at Alina, I was asked to take on responsibility for inpatient coordination across the system, really with a specific charge to improve length of stay. And through a lot of work, a lot of great collaboration, we ended up landing on it fundamentally as a deliberately simple method. Um, as I think many people listening to this know, every year CMS reports out on for every MSDRG um, that they have, the geometric mean length of stay associated with every one of those MSDRGs. And using some early data analysis, what we're able to do is to create a model where we compared actual versus expected. And what we used for expected was the geometric mean length of stay. And I want to be clear that expected didn't necessarily mean we expected every patient to be at it. We just used that as really kind of a line in the sand. And we ended up expressing that number as a percentage. And what it did is it offered a rough acuity adjustment that everyone could pretty easily understand and that everyone could pretty easily follow. And critically, it allowed us to be able to compare facilities, to compare um, physician groups, to compare just across the board. And that was what was so powerful. And a key advantage, I would say, to it as well is that it removed the usual, hey, mine are longer because my patients are sicker argument. Because fundamentally, if the benchmark for a particular group or particular discharge provider looked off, you could say that, well, that could be a documentation gap. And maybe if their patients are sicker, there's opportunities to do better documentation and improve coding to be able to raise that MSDRG and get it to a higher level. But if that documentation was accurate, the issue was most likely operational. So either way, it anchored the conversation in something that was actionable. And I would say what we learned early on is that, at least working specifically with providers, one of the most valuable ways of improvement was actually the Hawthorne effect, which is when people know that they're being monitored, they know that they're being reported on, or at least compared, it was incredibly motivating. And it created a lot of good discussions. We weren't doing it punitively. It was really just to have a conversation of saying, hey, we need to create capacity. We can't build more beds. So how can we utilize data to understand where there's opportunity? So because that signal was clear, we built it into dashboards and leveraged it operationally. It highlighted delays in consult timing, discharge planning, weekend coverage, like all of your traditional bottlenecks. It validated some of them, but also it invalidated some of them. Things that we had always thought were drivers turned out to not really be drivers. So by addressing these patterns consistently, we were able to save more than $12 million, and that was documented very much in direct cost avoidance over the course of about 3 years, all without expanding bed capacity. So it was, and at the end of the day, it was a very conservative cost calculation.
Yeah, and I think it also just helps, I think, in terms of expectations versus reality and measuring that, right?
Yeah,
There's what we think we know, as you said, and it's kind of challenging some of those assumptions. And while every patient truly is different with their background and their situation and their diagnosis and their treatment and all the the therapies and interventions, there are some things that are in common, especially when we start to aggregate the data and start to notice those kind of trends. So I think that's an incredibly insightful uh, program that you put together. And seeing the real cost savings is certainly something that the health system cares about. But also, there's an impact on patient lives, right? So there's always that, if you've had
absolutely.
a hospital stay for you or a loved one or someone that you care for, many of us are kind of, have elderly parents who are reaching that stage of life where hospital stays are unfortunately uh, part of what happens. It's trying to manage that as a family, right? And that's a very stressful period for people. And knowing that we're doing everything that, there's the treat 'em and street 'em kind of express version of healthcare that some people think is what's happening. That there's an eagerness for the hospital to get them back out, but there's obviously an eagerness to have successful outcomes for the patient too. And certainly, no one wants to be in the hospital any longer than they need to be. But it's about making sure that they have that successful hospital stay, get what they need, have the transitional care assistance, right, to make sure that a readmission risk is minimized as much as possible.
Yeah, and we would say, flippantly, or at least I would say flippantly, that, the hospital, an inpatient hospital bed is exactly the place you need to be for when you're really sick. But once you reach a point that level of care is no longer needed, it's a really dangerous place to be, right? Like that's where hospital acquired infections come, that's where falls happen, that's where all kinds of things happen. And so it's really this idea of having these balancing metrics, right? You're looking at, hey, we don't want to have readmissions because those are really dangerous as well. But we also don't want people staying longer than they need to. So at the end of the day, it's all about proportionality. And yeah, the way you outlined it, I think summarized it really well.
Yeah, that's great. So I think adoption of new technology in an organization of any kind, whether we're in the healthcare industry or any, is obviously challenging, especially the pace of innovation here with what we're seeing in AI. We're recording this at the end of 2025, and it's been 3 years since ChatGPT. I think 3 years and about a month since ChatGPT was released, which for a lot of people was their introduction to AI. It's obviously been around for much longer. It's been in products for much longer, but now, you can't spell anything without AI in it, right? It's kind of the wave that's hit us. Uh, But in our discussion before the show, you talked about this cycle and kind of your observation of how healthcare organizations have dealt with kind of the cycle around bringing in new tech and innovation and what they choose to bite off for themselves and their teams. So let's get into a little bit of that. Why do you see this building in-house, then leaning on partners as kind of a normal and healthy response to change like what we're seeing with AI?
Yeah. So I guess my argument is that this pattern seems, fundamentally cyclical. Um, Within kind of health system kind of operations, leaders usually bring or begin, I would say, by keeping those new capabilities in house. And that instinct is reasonable in healthcare because the work that they're doing is so mission critical. And as demand grows, they recognize that scale, speed, or certain kind of specialized skills are needed. And that's fundamentally when they end up turning to partners. So as that technology then matures, parts of it become more routine, more commoditized. And that organization no longer needs the same depth of external support maybe that they were seeking out from that partner. And at that point, it usually corresponds with a new wave of technology that's taking that kind of the core element and bringing it to a new level, reshaping those tools, the skills, the economics, and that cycle begins all again. But I would also say that there's also a really important human element to this process, and that's technology leaders are in these roles because they want to work directly with meaningful emerging technology. It's not natural for them to want to limit themselves to managing budgets and vendor lists exclusively. So, it's absolutely fair to understand that they want to build, to experiment, and move their organizations forward. That's what they're tasked to do. So when something new does appear, it's natural for those leaders to want to lean into internal development before kind of that practical need for partners to become clear. So this is, at least as I'm seeing it, very much consistent with what we're seeing in AI today and AI adoption. And so, our role is to support these leaders in that mission to deliver effective solutions inside their organizations. And that means respecting their desire to build, helping them to scale when it's needed, and ensuring at the end of the day that that technology can really mature into something, both reliable and operational, in order to kind of meet the opportunity that that technology represents.
So the cycle is similar in terms of the way that it's repeating, but do you feel that AI is somewhat different than other new tech that's come up over the years, and especially in terms of the way that healthcare organizations are looking at it and kind of seizing the opportunity or not seizing it yet? I think, AI adoption has been kind of interesting this year and been challenging in many ways.
Yeah. You know, I think my opinion is that AI is following a familiar cycle, but, only with a more powerful class of tools. So, as I described, when something new arrives, leaders usually want to test out or build that capability internally, right? Like, and as he said, um, they want to understand that technology, manage the risks, and avoid, potentially unnecessary dependence. But early work with the hyperscalers reinforces that approach because the first steps appear almost effortless, right? Like, so if you talk to any of those big hyperscalers, they're really willing to kind of create a model endpoint or connecting a data to a data lake that in a way that can feel really simple. But at the same time, many of those vendor reps actively encourage experimentation. Their guidance often sounds really supportive, but those underlying platforms are designed to maximize um, compute cycles, if I'm blunt, and revenue rather than kind of utility and efficiency. So organizations may assume that they're taking these small exploratory steps with AI, but when in fact they're building on a foundation that can grow really costly and complex as that usage expands. So the harder questions tend to kind of emerge later, which is, once at least within AI, once multiple business models and business units are involved, leaders start to have to confront some of these issues related to maintenance, reliability, interpretability, and workflow integration. So that's the point at which teams have to start looking at partners, and partners who could convert AI from a series of, experiments, if you want to call it that, into dependable operational gains. And where I've seen it at least get a really initial traction is more around administrative type tasks, as opposed to those tasks that are maybe specifically related to patient care, because that's the hardest part to do. And so in that sense, the pattern is the same. Internal enthusiasm leads that early chapter. Vendor incentives and momentum and partners become necessary when the organization needs, results that endure. And the last thing I would say here that kind of follows that similar pattern is you do get different types of organizations tend to have higher kind of early adoption risk cycles, and it follows kind of the traditional, kind of risk cycle distribution graph. And so, many organizations are looking to some of those kind of early adopter organizations to see how are they using these AI tools, and how are they able to actually utilize it in a way that makes care better, makes operations better, and frankly, I mean, if I'm really really putting my finger on it, it's how are they going to make, a model that is really struggling from an operations perspective in margin to be able to achieve a higher margin.
Yeah, I think it's a good point about the hyperscalers. So we're referring to companies like AWS, Google Cloud, Microsoft as the three dominant players. Their platforms that they offer to customers of all industries, of course, as you say, they rely on a consumption model in terms of how they earn their revenue, right? So the more workloads you're putting onto their platforms, regardless of what services it's using, all of that adds up, and customers obviously are signing consumption-based commitment contracts where they forecast out how much they're going to use. And so there's financial incentives to maintain the discount by moving more and more of those workloads into that cloud and trying to consolidate, usually with one cloud, one hyperscaler versus spreading across multiple and trying to get all of their additional workloads. So if you're doing maybe Azure, you might do Databricks on top of Azure, and then right, and you're getting kind of the. So I think that everybody understands those are commercial organizations. Their stocks are well known and documented and followed, and really, a big piece of the U.S. economy in terms of the way they work. So I don't think there's any secrets about kind of vendors and their motivations. I do think it is a good caution that you provide here, though, because the scale at which those operations can quickly no one wants to be surprised by a utility bill, right? It's kind of like
Right.
at home, right? Like who's been running, it's been very cold here in the Northeast over the last couple of weeks. Like all of a sudden you get the gas and electric bill, and the gas particularly went up pretty high because it's been so cold. Not a surprise because I pay attention to the weather. However, no one wants that surprise. And I think that is where we see in kind of the work that we're doing here at Productive Edge, AI is touching every part of the organization, right? It's a board level mandate, figure out how we can save money, improve operations and costs. Let's go ahead and get that, figured out. So it's touching every part of the organization. So there is kind of the many pots, kind of boiling and bubbling at the same time. There is that need and that opportunity to kind of consolidate. I do think the role of partners, and obviously we have a bias towards that because that's kind of the work that we do,
Yeah.
is helping customers figure out how to prioritize, how to build for scale, as you indicate, and then also how to manage risk, right? Because that's ultimately, healthcare as an organization or healthcare as an industry is highly regulated. The risk, the PII data, the PHI data, the compliance with laws, with policies, Medicare, Medicaid, all the different systems that are out there from the government at the state and federal level, right? There's a lot to manage. So when you're thinking about kind of risk and risk management, uh, and AI and kind of the opportunity here, what are you thinking about, and what conversations or what advice are you giving rather to healthcare leaders around risk and kind of accountability there?
So I think a fair way to say is risk and accountability shape AI decisions in healthcare, as you alluded to, in a very direct way. So, if you look and say, I've heard a lot of individuals say something to the effect of why is it taking healthcare so much longer to adopt it? versus maybe other industries. And I would say, leaders are not necessarily being cautious for the sake of caution. They're managing a real downside risk, right? Like a poorly governed model has huge impacts from patient safety. They can expose the organization to legal issues, or even something like just simply undermining trust. So stability and safety in healthcare applications of AI carry legitimate weight. Um, but I would also say that different leaders also hold different forms of accountability. So, CIOs, for example, are responsible for security, reliability, and tech budget. Clinical leaders, on the other hand, are responsible for patient outcomes and professional standards. And, those two incentives don't always neatly align, which is why AI decisions often feel so much slower or more complex than in other technologies. So my opinion is that meaningful progress happens with a process that kind of forces those perspectives to be bridged rather than in a conflict of like, hey, which side is going to win? When IT, clinical, and operational leaders share a clear set of outcomes and a common way to measure them, I AI initiatives can move forward. But when they operate in parallel, the work tends to stall. So my primary point of recommendation is clarity in the models, both in approach and ultimately what's going to drive us in the future.
Yeah, I think it's challenging, and this has been true with CIOs, I think, for as long as I've been in the industry, is that CIOs kind of catch a bad rap for just saying no to everything. Because saying yes to things introduces risk and challenge, and they spend, many CIOs have calculated out in their budgets the percent of their budget that is spent managing existing tools and infrastructure and applications, right? The technical debt, that many people talk about in the industry. How much of their budget, energy, effort is put into innovation and doing new work. I think they want to do more of that. They want to do it in a measured way, right, to manage risk and be able to control kind of what's happening and do things at scale and do things in a compliant and well-governed way. So it is definitely there's a struggle in terms of what those competing objectives might be. I love your advice around helping, from an organizational leadership point of view, right? If they drive to alignment on that and have a couple of kind of guiding principles or goals for the organization that they can work towards collaboratively with the peers, uh, then I think we're able to take those steps forward versus being somewhat paralyzed. And we see a lot of customers, moving from beyond pilot into deployed AI applications. That's been, I think, part of the transformation in 2025, and we expect that to grow and scale in 2026. So that's something that I know we'll see some progress around. In terms of the work that you're doing there with the Intelligible team, let's talk a little bit about that and kind of
Yeah.
the work and what's neat about the work there and kind of what's interesting and different.
Yeah, and I get really excited about this because through my arc of the things that I've worked around, it's always had a direct connection to data. And the reality is that most of the value in healthcare sits in structured tabular data. So think encounters, meds, labs, quality measures, even claims. And as you think about many of the large language models, they're really powerful. But at their core, they don't naturally understand that type of data at scale. They need a way to work with it safely, efficiency, and in a form, most importantly, that preserves meaning. And that's what Intelligible does. It provides that layer. So it allows leaders and analysts to ask questions of large data sets in natural language without relying on heavy SQL or long analytic cycles. So what we're developing is where a leader could surface drivers, explore variation, and receive explanations that make operational sense It also, we're working on tools to help support AI model review so that when a model highlights a patient or predicts an outcome, we have tools or we're building tools that can show which variables fundamentally mattered, how they behave, and the basis for that model's confidence. And this is really important to understand because what Intelligible does that's different is the research that it's built on is leveraging what's referred to as a glass box approach rather than a black box one. And you'd probably be familiar, think about most of the proprietary large language models are considered black box. You don't necessarily know what's behind the scenes in terms of how they're training, how they're making those decisions. A glass box, on the other hand, does allow you to see it and know it. And that's the way Intelligible is built. And the value in that is because, as I said, that distinction matters in healthcare. Clinical and operational leaders have to understand why an AI system is suggesting something. They're accountable for patient safety, regulatory compliance, prof- basic professional standards. And a, a black box answer may be technically accurate, but it's difficult to trust, really hard to govern, and difficult to audit. Whereas a glass box solution answer allows clinicians and operators to examine the logic, validate it against their real lived experience, and decide whether it's appropriate for their specific population. So, looking ahead, what Intelligible is working on delivering is giving large language models structured access to healthcare tabular data. And by doing that, it really, not to sound overly dramatic, but it changes what's possible. It moves us away from handcrafted data pipelines and static reports towards systems that understand both the structure and the meaning of data. Leaders will be able to interrogate data quality directly, receive coherent explanations that are defensible, and adopt much more quickly to emerging operational needs. I guess to summarize, in short, we're working on speeding insight while preserving interoperability and accountability that healthcare data requires.
Yeah, which is something that I think healthcare leaders have long struggled with and yearned for, right? Every time we've spoken with anyone who's focused on analytics, data reporting for a healthcare organization, whether that's payer or provider, they always have a backlog of work, right? It's in some ways been like job security because they were the only people who knew how to, access the data, where it was, and write the SQL code and run the reports and those kind of things. I still think there's job security for those people. It's just they're going to work on higher value tasks. But now, as you're
Yes.
saying, it's a bit of the to use the phrase in the industry, democratizing the data, right? So that now I can sit down in front
Yeah.
of a console and speak natural language, ask questions, be curious, dig deeper, right, and kind of keep on probing the data to try to get those insights, especially where there's so many, going back to your example from the beginning at Alina, there's things that assumptions that we all have about kind of how things work or why things take the time they take or what it might be. Now being able to ask those questions of the data and have it put together in a consumable way. And easier to kind of acquire and interact with is certainly a game changer for many organizations.
It, absolutely. Yeah. And I keep telling people that it feels like what we're going through with AI right now, it's dog years. The amount of progress that's happening in 1 week feels like 7, right? Like things are moving so fast. And frankly, I'm just incredibly excited to see, what 2026 and in the next subsequent years are going to bring in this space.
Yeah, absolutely. Well, I won't ask you to predict too far into the future, but for healthcare leaders who are working on AI planning for 2026, do you have a couple of suggestions, areas to focus on, or kind of some advice?
Yeah. So I guess what I would say is first to be clear about what you truly intend to own long term and where you're going to need partners. Some organizations are going to, clearly have stated that they want to own the data model and governance, but maybe they're comfortable renting the models. Others want to own particular clinical or operational programs end to end. So, what really matters is what I would say is clarity about those boundaries. The second is to make sure, and I touched on this earlier, is to tie AI efforts to operational outcomes. The earlier you do that, the better. Don't necessarily think of them as pilots. Think of them as kind of you're testing something operationally, and establish the baseline, define the target, and agree on how it's going to be measured before any of the modeling starts. I I can't think of another way, but that discipline prevents drift and keeps that work fundamentally grounded in what you're trying to measure. What is the organizational value? What are they hoping to get out of it? And it becomes more than just, what you might call like a science experiment. The third would be to stay as modular as you can. So do your best to kind of keep your data and your architecture in a form that allows you to change models or vendors without rebuilding everything. The landscape, as I said, is moving so quickly. So modularity is what's going to give you room to evolve without kind of that unnecessary lock-in. And by no means am I saying don't try things. You don't want to be left behind, but also don't go marry something so closely that then when something better does come along, you're locked in. So, you know, this is just my opinion, but those three principles I think can really help an organization to stay focused, aligned, and adaptable as that technology, as I mentioned, continues to advance at just incredible speeds.
Yeah, I think it's a really challenging environment because you're being pushed by your leadership to move forward, to act, to do things. But we all know, even if something as simple as, our son went off to college this fall, we buy him a laptop. Of course, a couple months later, something better comes out. We've all been through this cycle and kind of the Moore's law, not this Moore, the other Moore, law about kind of the pace of innovation and change. So definitely a challenging environment, but really some exciting opportunities and some amazing work being done across the industry. So this was a great conversation, Mark. I think what I'll take away from it is, healthcare organizations aren't stuck because they're behind. They're navigating some real risk and some complexity with the tech changing every year, and that cycle of building internally, bringing in partners to help. It's a smart response to the environment, right? You're using partners and their expertise, and the hyperscalers are investing in customers as well because they want those consumption dollars, right? So, there are kind of aligning some of those objectives, both internally and externally with partners and vendors, can really help accelerate the pace of change. So, that opportunity around AI, I think it's being intentional about that cycle is what I'll take away from our conversation today. And knowing and making those thoughtful decisions about what you own, where you want some help. Your point about the clinical goals and being tied to that technical path, I think, brings it all together. So this has been a really useful and insightful discussion, Mark. So thank you so much for being with us.
Thanks for having me. It was an absolute pleasure.
All right. And for everyone listening, if you're planning your AI moves for 2026, I hope this gives you a clear path and way to think about the trade offs. Please share the episode with a teammate who's in the middle of those decisions, and go ahead, like, subscribe, comment, and share if you want to follow the Health Tech Edge. So thank you very much for your time today. This is Mike Moore and the Health Tech Edge, and we appreciate your time.